of treating diabetes. One of my colleagues in the Access Campaign worked in South Sudan. He told me about the days that he spent up all night as well treating a child with diabetic ketoacidosis. And then when he asked in terms of what the plan was for this child on discharge, he was told that unfortunately we couldn't provide ongoing care. Another colleague working in the emergency room in Ethiopia told really kind of another interesting story. He would see children coming maybe 2-3 times a week to the emergency room in order to get a shot of insulin. And what he discovered was that families had moved to live closer to the hospital in order to enable their children to come on a regular basis to the emergency room. So coming from what I now kind of feel is the slightly luxurious world of HIV, I started to kind of ask myself, what is the problem? What are the main barriers that are making this so difficult? Is it the cost of the insulin? Is it the complexity of the regimens? Is it the cold chain? Although MSF has already presented and shown that we can use insulin for a month out of the fridge using traditional kind of cooling techniques. Or actually, is it the fear of the word chronic? In HIV, we debated this at length when we first started. But in 2001 in Uganda, I would never have thought there'd be a global fund or PEPFAR. And if we hadn't started, would we now have 20 million people on treatment? Insulin is also going to have a birthday next year. It's going to be 100 years since insulin was discovered. Dr. Banting, who discovered it, sold the rights of insulin for $1 to Toronto University. The median price of a vial of human insulin is about $14. It varies hugely country to country. Put that insulin in a pen, so it's a bit easier to deliver it, the price is 3 to 4 times as much, and the newer analog insulins, again, the price is escalating. There are 3 companies that make insulin: Novo Nordisk, Eli Lilly, and Sanofi. Those 3 companies dominate 99% of the insulin market. There is no competition. The generics of insulin are called biosimilars. I think calling them biogenerics might make it easier to understand. The processes those companies have to go through to get their product approved in Europe and in America, and therefore for use in MSF projects, are extremely costly and extremely complicated. So in the campaign, we're asking, can MSF, as we've done for hepatitis C more recently, help to speed up and simplify those regulatory processes and try to get some more competition in this market and start to work with biosimilar companies? But I know it's not just about the insulin. We're going to hear this afternoon about some fantastic work MSF has done treating type 1 diabetes. I know we do it in Eastern DRC, in South Sudan, some really difficult contexts. But my feeling is the examples you're going to hear today are the exception rather than the rule. So how can we learn from others? Well, I think in MSF, we have a lot of experience managing a chronic disease, and that's HIV. And we've done that for children and adolescents as well. One of the best sessions in the training I do every year is when we bring the adolescents and young people from our clinic and they tell our participants how they want their clinic to be run in a person-centered approach. What can we learn from others? Well, at the campaign, we're starting to network with a fantastic group of type 1 diabetics who are adapting technologies to make it safer to treat type 1 diabetes and to improve their quality of life. We had a call with this amazing Brazilian paediatrician who, with his biomedical engineer sister, has designed a 3D printed pen to make provision of type 1 care easier. He's treating children from the favelas in São Paulo. So again, those children would not have access to the expensive commercial devices. And the pipeline is also exciting, with ideas like smart insulin, which could really revolutionise and simplify how we treat type 1 diabetes. So finally, how can the Access Campaign and operations really look to do this together? How can we work together to improve access to care for diabetes? In the next couple of months, we've got 2 workshops organised, one in Lebanon and one in Nairobi, where we're bringing together different projects from the field to really hear from you on the ground what your challenges are, and to try and make a plan together for implementation and for advocacy, how we can improve this for the patients in front of us. Should MSF start using biosimilar insulins and not buy from the big 3? Can we use this new technology to provide care that stops complications and doesn't just keep people out of the emergency room? And so in summary, I challenge us, should MSF be part of the conversation to ensure that this child in the picture is not just treated in the emergency room, but for life? Thank you very much.